I'm Beth Freestone. I'm an interventional cardiologist working from Birmingham. We're here at ACI 2020 in London to talk about cardiogenic shock. So I'm going to introduce to you our panel of leading UK interventionists. So we've got Professor Tony Gershlick from Leicester, Professor Keith Aldroyd from Glasgow, and then Dr. Fath Udabadi. Is that about right?
Close enough.
From Manchester. So obviously it's an important topic, and that's why we're here. We all deal with it in our everyday acute myocardial infarction work, primary PCIs. They're our sickest patients. They do the worst, and I think, you know, with the high mortality, we've still got a lot of work to do. So first of all, Tony, if you could just recap what the size of the problem is, really.
Thanks, Beth. It's great to be here. The situation is that the incidence of cardiogenic shock has actually been falling somewhat, and that's partly to do with the fact that we do primary PCI so much quicker, and we get to the patient so much quicker. But I think most of the data suggests that it's still between 6 and 8, 10% per year.
Yeah.
And as we all know, a small percent of a big number is a big number. There's a lot of primary PCI, a lot of infarcts, a lot of STEMIs out there. And we've calculated it probably correlates with about 50,000 deaths per year in Europe. And the reason that there are so many is because, as you know, there's a 40 to 50% mortality in the first 3 months, which plateaus and is no different of 1 year. So we have a relatively uncommon condition, but affecting a large number of patients with a very high mortality. And it's often said that, you know, if this sort of mortality was the same sort of mortality you have in cancer patients, then the research funding would be much higher. In fact, the number of patients who have been funded in research trials is incredibly small over the last 20 years. So that's the size of the problem. A population of patients who present unwell and who, if you don't treat rapidly, get into this spiral, so they get this adverse events secondary to compensatory mechanisms, so increasing adrenaline, noradrenaline, sympathetic drive, all of which add to the ischemia, and all of which causes increased peripheral resistance and makes pump failure so much more common. Final thing to say is, of course, that if you look at the curves for mortality, it's all happening early. So it's not a slow curve that just accumulates over the first 3 months. It's a curve that looks like that, which means that if you treat the patients early and can reduce that very early mortality, and landmark analysis, say from complete shock, culprit shock trial, suggests that if you can treat them early, then you can make a big impact. There's very little attrition late between 3 months and 12 months. So early intervention, if we had one, is very promising in a small percentage of a very high-risk population that leads to a large number of deaths.
And quite often it's our cardiogenic shock patients that do have some delays in coming to the lab, isn't it? They're a pretty heterogeneous population. It includes our out-of-hospital cardiac arrests, where there's a lot of sort of delays in intubating, trying to hemodynamically improve the patient before they actually get to the cath lab and get their primary PCI, and then you're sort of already on that downward spiral of your sympathetic overdrive and your microvascular resistance and damage going up, and then your multi-organ failure.
So we do just need to say, of course, to this audience that the only trial that really had an impact was Judith Hockman's trial, the SHOCK trial, which was some 20 years ago now. And that showed that what we're doing, which is taking them straight to the lab and revascularizing them, is absolutely the only treatment that's shown to be effective over the last 20 years. So we shouldn't in any way impact upon that standard of care. What then happens, of course, is that the other interventions are sort of slightly untested as such and slightly more invasive, and so there's a sort of reluctance to do anything more until this spiral goes down, and then it's too late. Yeah. And then you're putting mechanical support device, we'll hear a bit later on, in much too late.
We'll just say also, when we were setting up primary angioplasty, we concentrated on the bigger group, so we got everything protocolized, time to balloon sorted, and we become very slick, and that's where we're getting lots of good results. But we kind of did not take into consideration the smaller group, and I would add out-of-hospital cardiac arrest to that group, and we never kind of produced a protocol to really treat them in the same way in terms of how fast we treat them, let alone using devices. So in a way, there is this dichotomy where the sickest patients we don't have any protocol for, but the ones who are less sick, we have a very good protocol.